So he had two implants that were placed in the wrong position and had insufficient space to accommodate what he needed. And they were left there for a number of years because they couldn't restore it. It was left supposedly under the gum. It caused some bone loss around the implant on the left. So this particular implant was still buried, although losing some bone on the side wall. Okay, we're removing the other implant now. So the longer you live without any stimulation to the bone, the more bone you lose. And an implant requires bone volume, both in vertical and horizontal dimensions. So in the lower jaw, for example, we've got the main nerve canal that supplies your lower teeth and jaw with blood supply as well as sensation. So if we lose height above that nerve, then we may not have enough to place an implant. All the implants are out now. He's only had 2 implants on the bottom jaw.
So as you guys know, we're busy with a full arch case at the moment, or a neo arch case. And in simple terms, what we're doing is a patient that currently wears a full upper and lower denture, we're converting them to a fixed denture. The pan that I have up here is a classical situation of where we would hope things to be. Basically what happens is, after wearing a denture for a long time, there's bone loss that occurs naturally. Whether it's just bone loss because the teeth are not there or an ill-fitting denture, but the net result is that there's been bone loss. In the lower jaw specifically, the consequence for future implant work is that there's a nerve canal that runs in the mandible. It's called the inferior alveolar nerve. And if we wanted to place implants to restore this patient to a fixed rehabilitation, the height available of bone above the nerve to the crest of the bone doesn't allow a standard length implant to fit in there. And at times even a short implant doesn't fit in there. So what the surgeons do for us is, yes, the surgeons are cool, they place implants at angles. And with an implant placed, the 2 distal implants placed at angles allows them to engage the good bone in the anterior mandible where there's no nerve. So that nerve runs down the mandible but stops around where the premolars used to be. And there's no nerve in front. So the implants can be placed at angles. Where we become cooler than the surgeons is that we can now add attachments, or almost in simple terms elbow joints, onto the implant that straightens up the emergence. Because obviously currently if the implant is placed at an angle, my prosthesis needs to sit flat down on a flat implant interface. And we place these butt joints to correct that angle. Similarly, in the maxilla, when there's alveolar bone loss that occurs, we have the maxillary sinuses that become quite enlarged as well. And as the same as the mandible, the amount of space below the sinus and the crest of the ridge is not enough for a standard length implant. So surgeons will place implants at angles to skip the sinus, because there's obviously no sinus in the front of the face that affects implant placement. And that's how we go with a full arch reconstruction in this type of situation. So ultimately what's happening right now is Dr. Bansi is placing those implants, and once the implants have been placed, I'm going to get in there and choose the correct angled abutments to use here. These abutments either come as 0 degree, or they come as a 17 degree or a 30 degree. And I choose the correct angled abutments with the correct heights. And the height would basically mean how deep his implant is placed in relation to where the gum is. So the implant is placed on the bone level, the gum level is slightly higher than where the gum is slightly higher than where the bone level is. So angles and heights become important at this stage here. Place the abutments, make sure all my abutments are parallel, and then we can take the impressions from there afterwards. Let's go have a look. Implants were placed at angles like I showed you earlier, and this is just a try and pin to see that I've been able to re-angle it adequately. So I use 30-degree angle corrections on the posterior implants, because obviously those were the implants that for him placed anteriorly. The blue one here is a 17 degree because the mandible or the bone resorbs in such a way that Fahim was only able to place the implant in that position, so I will re-angle that with a 17 degree joint. It's minimal, but it'll look better at the end. And this normal gold one here is just a straight one. So this implant was placed. It was placed in good bone and was able to be placed prosthetically in the correct position as well. Impression material needs to be nice and rigid as well. You don't want something that's going to be too elastic. Pretty much the impressions are taken. The bite registration has been taken as well. So the patient gets to recover. All of this work, the impressions go to the laboratory, and the guys from Inline will start manufacturing the prosthesis on the implant analogs. It's Thursday afternoon now at 5 o'clock, so we'll probably have things ready for him by tomorrow afternoon, and then we can deliver some teeth for him. It's obviously important that we get these teeth loaded. Immediate loading in essence is where you can load these implants within a week, but we want to get these implants loaded ideally within the first 48 hours before any swelling does actually kick in. So he will have a bit of pain this evening, but the swelling will kick in from 48 hours beyond, 48 to 72 hours. So we're going to get the prosthesis in before the swelling happens, so it makes delivery a lot more comfortable for him. But let's see how this goes.